All right, are we good now?
Yes.
Okay, then let's go ahead and get started. So just as a quick background, monkeypox is an orthopox virus. It's part of a larger family of pox viruses. Orthopox is actually the genus. And in this particular genus are 4 fairly closely related viruses. Obviously, the one we're focusing on quickly tonight is monkeypox, smallpox, which I'm sure everyone is aware of, which is the first and only disease that we actually were able to target and eradicate. The only existing stockpiles of smallpox that we're aware of in the world are actually kept by the CDC here in the United States and by their counterpart in Russia. And so the concern, of course, for smallpox is really would be an accidental lab release or a bioterrorism event. But other than that, it was eradicated. The last known natural case actually occurred in Somalia in 1977. As you guys know, we did vaccinate, and that's how we were able to eliminate the disease. The vaccinia virus, which is the same genus and closely related, and because it causes a similar immune response, was the vaccine that we actually used to eradicate smallpox. But that virus and that vaccine do still exist, which we'll talk more about in a few minutes. And then there's the cowpox virus. These viruses are what we call zoonoses, meaning that they are diseases that commonly occur in animals, but that can be spread to humans. Most of the time, the animals are the main host and human spread is accidental, but sometimes these diseases do become what we would say normal in the human host after transmission occurs. Obviously, in this case, we're hoping that will not happen because what we don't want to have is sustained human-to-human transmission. It's not exactly clear what the normal host species are, but based on the transmissions that we've been aware of, it does appear that it's small rodents that are most likely, and not monkeys. Can somebody mute their phone? Can you guys hear me okay?
Yes.
Yep, sorry about that. So it does appear that it's probably a series of different small rodents that occur in the countries in which it is endemic in Africa. And if any of you have seen this or remember, in 2003, the first large-scale outbreak actually of monkeypox occurred in the United States, and that's because someone imported some small rodents from these African countries, and it turns out they were infected. They managed to infect some of our local rodents, specifically prairie dogs, and then humans who had them as pets were exposed. It caused actually 47 cases of the monkeypox back in 2003. So that was our sort of original experience. Occasionally there's been some travel associated exposures, but that was the only really large scale outbreak up until that time that it occurred outside the normal range. So why is it called monkeypox? Well, the reason it's called monkeypox is because back in around 1958, the disease actually occurred in a couple of colonies of monkeys in Denmark. And this was a disease that had not previously been seen. They named it monkeypox because of the fact that they saw those outbreaks. But it was later, of course, that they learned that monkeys, like humans, are not the natural host of this virus. And so monkeypox is actually kind of a misnomer. You may have seen some of the news suggesting that the World Health Organization is actually looking into renaming this, although I haven't seen anything yet that suggests what the new name is likely to be. So where is it actually normally found? It's found in sort of that central and western part of Africa, Nigeria, the Democratic Republic of Congo, and the surrounding countries. All of these countries are contiguous with each other. So if you looked at a map, they're all touching each other. But it's interesting, despite that, there do appear to be 2 different clades, which I'll talk more about in just a second. And the DRC is really where this disease has been most prevalent. The DRC actually has more than 5,000 cases of this a year. And because of that, the CDC and other organizations like the World Health Organization have actually put some resources in the DRC to study the epidemiology and clinical findings of the disease. And that's in part why we have some data with regard to the vaccines that we're using, as well as the medications, which I'm going to talk more about in just a few minutes. So before this large outbreaks, there were sporadic human infections outside the endemic area. And as I noted, other primates. As I also briefly mentioned, there are two different clades or sort of subspecies of this virus. The West African one, which is the one that is seen broadly in Nigeria and the countries up in that area. And then the ones in the Congo Basin, which the DRC is the main one. Again, these countries are all right in the same region, so it's not like they're widely separated from each other. There are some substantial differences between the two viruses. If you actually look at papers that talk about the virology, there are definitely differences in their DNA sequences and some differences in their proteins. Their clinical presentations are different. For example, the Congo Basin one is considered to be more severe. Traditionally, before we got data on the new outbreaks that are occurring, the estimation was that the case fatality rate was about 10% for the variety in the Congo Basin and about 1% for the variety in West Africa. However, more recent data, probably because we know more about the disease and we have better medical care, have suggested the case fatality rate is more in the 3 to 6% range. And we'll talk more about that in just a minute about the risks for the groups that might be immunocompromised or have other reasons that they'd have more severe disease. So how is it transmitted? It's mainly by physical contact. So human to human transmission is typically by contact from one person to the other by the infected lesions themselves. However, there is definitely fomite transmission that occurs. And so, for example, if the person contaminates the bedding or towels or their clothing and someone else comes into contact with it, then they could potentially transmit it as well. But human to human close physical contact, just because there's a lot more opportunity for contact with the virus, is the main mechanism whereby it is spread. There is the possibility of large droplet transmission, which will be close in, so that sort of 3 to 6 foot range. This virus is shed in respiratory droplets, but it does not appear to be an efficient mechanism of transmission. And if you look at the recommendations for how to quarantine people that have been exposed, they really talk about issues with respiratory droplet transmission risks only if it's a very prolonged risk. And if people are masked, it's believed to essentially eliminate that risk. There is potential for aerosolization, for example, if you're doing an aerosol generating procedure, but that is not the normal way that this is transmitted, unlike COVID. So with this type of transmission, that's why, as we'll talk about in a few minutes, why there's specific recommendations about particular types of PPE to protect yourself and prevent transmission. And I would note that as of now, I'm not aware of any cases of healthcare associated transmission that have occurred in the United States, and it's only been very rarely described in other outbreaks in the endemic countries in which it occurs. So healthcare associated transmission, although certainly theoretically a concern and possible, is much less likely to occur than, say, something like COVID. So the incubation period, so the period from the time the person's exposed until the time when the symptoms develop, is typically 1 to 2 weeks. However, it can be as short as 5 days and as long as 3 weeks. The data that we gathered from the original description of the disease in its endemic countries suggested that in most cases there was a prodrome that lasted 1 to 3 days. It's your typical infectious or viral prodrome in which there's fever and flu-like symptoms, so body aches, fatigue, and then lymphadenopathy is quite common. This has been actually very well described with this disease in particular because lymphadenopathy was actually quite unusual with smallpox. And so when both of these viruses were circulating before smallpox was eradicated in endemic countries like this part of Africa that we're talking about, which is also where smallpox was occurring most recently before it was eradicated, it was a way that you might be able to distinguish whether somebody had more likely smallpox or had monkeypox, because smallpox really wasn't associated with adenopathy. The rash tends to occur on the skin as well as on the mucous membrane, so in anthems. So rash in the mouth or the pharynx can occur, as we've learned, and we'll talk about more in a minute, can also occur on other mucous membranes, so in the urethra, in the rectum, and other such places that can lead to complications that really weren't well described before. Similar to smallpox, this rash actually tends to be centripetal. And what that means is that it is more common on the extremities, and it is seen on the palms and soles, which is true of smallpox as well. This is true of only a few diseases. For example, if you look at infectious diseases, syphilis is another one that can occur on the palms and soles, and that's one of the reasons that syphilis is in the differential when you're looking at this disease. But for example, chickenpox typically does not occur on the palms and soles, and the rash for chickenpox tends to be more central, so it occurs more on the trunk, whereas this tends to be more on the extremities. The rash typically evolves starting as a macule, meaning it's flat, you can't feel it. Then it's a papule, so you can actually touch it. Then it becomes a vesicle or a blister, which then becomes pussy, and then it crusts over, and then the crusts fall off and new skin forms. This takes 2 to 4 weeks, and they are considered potentially infectious until the crusts have fallen off and the new skin is formed, which can take up to 4 weeks. As I already mentioned, the mortality was believed to be higher earlier on, but more recent data where we probably have better medical care and better epidemiology suggests that even in the higher risk clade that occurs in the DRC, that it's about 3 to 6%, and it's definitely higher in children and people that are immunocompromised. There's also almost a 10% secondary attack rate for unvaccinated household contacts. So these, of course, would be people that would have very close contacts. They might be sleeping in the same bed with them, or certainly in the same area. There's a lot of opportunity, sharing towels and clothing and whatever. So as most infectious diseases, typically more spread in households. It is considered contagious from the start of the prodrome until the crusts separate and new skin form, as I mentioned before. But that does mean that from the time that somebody is exposed until the prodrome starts, they are not considered to be contagious. So that's a little bit different from COVID, where we've learned that you certainly could be contagious before the start of symptoms. So here's a picture of what the rash typically looks like. These are those umbilicated lesions that you have heard about. I can tell you that I actually did get the opportunity to see a patient who's hospitalized in San Diego, and this is very much what the rash looked like. Obviously, depending on what part of the body it's in, we'll have some determination as to how it looks. In terms of where we are in the outbreak, if you look at the global number of cases, we're now above 26,000, and all but 350 of these are in non-endemic countries. So these countries in Central Africa where it typically occurs, there have only been about 350 cases in this period of time since the epidemic started, whereas globally more than 26,000. There are now more than 80 countries that are not considered to be endemic that have had at least one case, so travel-associated cases. And as I note here, most of them have not traveled to endemic countries, so the exposure actually took place in the country in which they are residing. And as I also mentioned, there are 2 clades. This is the West African clade, which has been noted in the past to be less severe and with a lower fatality rate. I saw today that so far they have reported 10 fatalities this year. 5 of those are in endemic countries, 5 of them in non-endemic, but we have not had any fatalities yet reported in the United States. In terms of the US, as of when I looked earlier today, all but 2 states appear to have been infected. It looks like, I think it's Wyoming and Idaho, if I remember correctly. It's 2 states right next to each other. I'm sure they're going to have cases as well. They probably just haven't reported them yet. We've had more than 6,600 cases in California. We're well over 800. And I will note that our neighbors around us, for example, San Diego has in the neighborhood of 50 cases, and the other counties around us, LA has quite a few. The other counties have reported cases as well. Cases are being reported in Mexico. I've only heard of 1 case in Baja, but I suspect that as the reporting gets updated, that number probably will increase. And I haven't looked in the last day or 2, so it might have increased. We have had our first case in Imperial County. I will note that that particular case was someone who actually was exposed and contracted monkeypox outside of Imperial County, but because he is an Imperial County resident, it does count as a case. We've also got 1 other case that we worked up earlier this week. We're pending the lab coming back, so for confirmation, but from the looks of the lesions, I'm going to be quite surprised if this one doesn't confirm, although this one will actually be determined in Imperial County because our medical providers saw him here. The exposure again occurred outside of the county. So as of now, we don't have any evidence that there is transmission taking place in the county. The cases are coming from elsewhere. The vast majority of these remain, as described early on in this pandemic, to be MSM, or men who say that they have sex with men. There have been now some household contacts, and including a couple of children. However, there have not been any links between any of the clusters. And as I noted, the cluster and cases we're seeing here in the States have not been related to travel in endemic countries. So these are basically transmission events that are occurring in the United States. So as I was noting before with regard to transmission, what we're finding in this particular outbreak, the epidemiology is showing that the transmission is occurring in contact with people who have a similar rash or a monkeypox diagnosis. It's the vast majority of them are MSM. Certainly people who travel to a country with a confirmed case are considered to be higher risk, or a country where monkeypox is endemic, although that doesn't appear to be what's driving the transmission now. We also know that contact with a living or a dead animal or exotic pet animal from endemic countries or a product made from such an animal can occur. As I described to you earlier, that outbreak that occurred in the United States in 2003 was associated with local rodents, in this case prairie dogs, who did get infected because they were exposed to African rodents that had been brought over in the pet trade. So I kind of described earlier what the typical presentation had looked like in prior descriptions of this disease. However, in the current outbreak that we're having, we are seeing that there are definitely some differences in how these patients are presenting. I think that has to do with how they're being exposed in the population that it's in. As an example, although I would say the majority of cases that at least have been described previous to this did describe a prodrome and then the development of a rash a few days later, there are a substantial number of cases that are occurring in the United States in which they are not describing a prodrome. So they're not complaining of fever or body aches or other issues before the rash actually develops. What we're also seeing is the rash is occurring in very specific locations. These are likely the locations where the actual contact occurred in the first place. And so because of the population that it's spreading in and the types of contact, we're seeing the rash in those areas. I can tell you, for example, the case that I saw, that it was a very, very significant and very painful rash that was occurring in the genital area. And it did lead to some complications, including difficulty with urination and severe pain. And that's why it was necessary to hospitalize this particular patient. So those are the kind of things that we want to be mindful of. And so it's very important that if you see someone in which you are concerned about monkeypox or suspicious because they have a rash or a prodrome, that you really examine their entire skin surface, including their skin, their mucous membrane. So you need to look inside their mouth. You should look in their rectum. You should examine their perineum and the surrounding areas very, very closely, because it is certainly possible that there are lesions there you would otherwise miss if you didn't specifically look for them. The other thing that I would note is it's really important to keep a broad differential diagnosis. As I think all of us remember from medical school, if you hear hoofs, you think of horses, not zebras. In this case, we need to think about both horses and zebras, because obviously monkeypox is sort of now no longer a zebra, at least in the United States with so many cases. But the point is that there are many other rashes that could have some similarities to this. In addition, this particular population is certainly at risk of other diseases that can present in a similar fashion. And they have found that a minority of cases have been co-infected with other things like gonorrhea, chlamydia, HSV, or syphilis. And so please consider these in your broad differential when you see these patients. It's also important to think about other things, for example, in pediatric populations. And the first suspect case that we had here that had a suspicious looking rash and a travel history was actually a child. And so we did test for monkeypox. Not surprisingly, the test came back negative. However, we also did consider the other things, including enterovirus or hand, foot, and mouth disease, which we did send off those lab tests. And that is what ultimately ended up being the diagnosis. But I can tell you, somebody please mute if you would, please. I can tell you that the lesions did look umbilicated and certainly were suspicious for monkeypox. But things like erythema multiforme and Stevens-Johnson, especially with infectious diseases or with drug eruptions, other types of drug eruptions, scabies is certainly in the differential. And then, as we already noted, things like herpes simplex, either one or two, varicella zoster, and then lymphogranuloma venereum are also considerations. Certainly, you could see chancroid, but that would be quite unusual, just like granula inguinale, because those are not common diseases in the United States. So if somebody has a travel history to a tropical or subtropical region, certainly might consider those, but they wouldn't be the first thing I would think of here in the States because they're very, very unusual. And then keep in mind, as I said, to test them for syphilis. It would be very appropriate to do syphilis serology on all of these patients that had a history that suggested that might be a concern, and keeping in mind that there might be some similarities in the rash, particularly the location. And then finally, if they haven't been evaluated for HIV or their status is unknown, it's certainly appropriate to consider testing for that as well, depending on the circumstances and the history that you take. So how do we prevent this? Well, the main reason or mechanism that we try to prevent this is by preventing exposure. That would be the most effective and best way. And that's why there are the recommendations out there that you guys have seen with regard to limiting exposure to populations that might have an increased incidence and risk of monkeypox. And that messaging will continue. But talking about sort of specific things that we can do to prevent spread of this disease would be vaccination. So the old smallpox vaccine that many are probably familiar with, and many of you, if you're old enough like I am to have received, was the old drypox live vaccinia vaccine. That vaccine was actually replaced and destroyed years ago because this new one, ACAM 2000, came along. It is actually a very similar vaccine to Dryvax. It was actually developed from a clone of Dryvax. The only difference is that rather than being made in the skin of calves, which is how they made the old Dryvax vaccine, is this one follows modern good manufacturing techniques, and they actually make it in a cell environment so they can control the manufacturing. It's still a live virus. It still has all of the same risks and benefits. It's just a more controlled manufacturing process. However, Dryvax is no longer available. As I said, they destroyed it, and ACAM 2000 has replaced that. As you're probably aware, back in the 70s, routine vaccination for smallpox in the United States went away. Subsequent to that, there were still some populations that got vaccinated, for example, some in the military and certain laboratorians or public health or other governmental response people in case of a bioterrorism event. But for the general population, use of the vaccine was discontinued. After 9/11, there was some increase again in public health response groups, the military, et cetera, but it's still not being used in the general public because of the very low risk that there would be smallpox, the fact that you could actually start vaccination campaigns afterward, and the fact that the vaccine does have very significant and concerning side effects that we'll talk about in a second. Interestingly, if you look at the outbreak of monkeypox that occurred in 2003, there were 47 cases. 3 of those cases actually had been immunized with the old vaccinia vaccine. However, the rest had not. So it is clear that there was not complete protection if somebody had been previously vaccinated, but there definitely was a decreased risk in those that were vaccinated. And the 3 that were vaccinated, none of them had any severe sequelae. So there is definite evidence that the vaccine previously used for smallpox does offer some protection that likely wanes over time. And that's why there's recommendations with regard to booster doses that we'll talk about in a minute. And then finally, there's the vaccinia immune globule, which has been around for a while. And we've used that in cases where somebody did get the vaccinia vaccine and had complications, but it could be used for somebody who got exposed to monkeypox and either couldn't get vaccinated or vaccine was not available. So for treatment, usually supportive care is all that's needed. As I noted, these people can have substantial pain, and depending on the body part, there can be dysfunction that limits their ability to eat. For example, if they get very severe oral or pharyngeal monkeypox, or as I already noted, urethral monkeypox. So those things can lead to the need for hospitalization for pain management. Also, interventions, obviously, to prevent complications like urinary retention. And these are people that we would potentially want to treat with antivirals, which we'll talk about in a second in more detail. Those antivirals could include tecovirimat or TPOXX, as you may have heard it called. There are oral and IV formulations, but just know that the public health supply that's being dispersed by the federal government to the state governments to the locals is the oral drug. And whether somebody is hospitalized or not, they would be receiving the oral drug. If for some reason they cannot take the oral drug, if it's not available, there is an IV formulation, but we would have to get that on a case-by-case basis from the state health department. There are other drugs that are active against these pox viruses, cidofovir, which I'm sure many of you are familiar with, particularly if you have HIV patients, but we all know there are severe complications of that, including renal effects. Brencidofovir is also effective, but it's not readily available. If somebody does happen to have ocular disease, then trifluridine is effective and could be used. And I already mentioned the vaccine immune globulin. And then there's some evidence that immune plasma from recent vaccinees might be effective as well. So we do have some options for treatment if they're necessary. Importantly, we don't have a lot of them. So if this were to become a very widespread outbreak, we might not have as much as we would need. Who are the high risk groups? In other words, who are the people that might need treatment? Well, obviously, anybody who has really severe disease. So some of the things that I just discussed, if they had encephalitis, if they developed sepsis, or people that might be immunocompromised. I'm not going to read this list to you. It's the typical list that the CDC puts out there. So, your people on steroids or other immunosuppressive drugs, people on who have poorly controlled HIV, your cancer patients who are on various chemotherapeutic agents, or people that have had transplants. So this would be the main ones that you would have concerns about. So we already sort of talked about some of these complications, so I'm not going to spend time talking about them. Again, I would note that if they do have lesions in areas that are leading to complications, that would be another reason why you would want to intervene and why you might use either TPOXX or one of the antivirals if you didn't have TPOXX available to you. So what about safety protocols? In other words, how do we in a healthcare situation prevent transmission to others? Well, the recommendations are that you would put the patient in a single room, close the door. If you're going to do an aerosol generating procedure, then they need to be in an airborne isolation room. But under normal circumstances, that's not necessary. You do want to try to cover the lesions of the patient, and you would ask them to wear a mask if possible. The healthcare worker would be using what I would call enhanced droplet precautions. You need eye protection, similar to what you would with a COVID patient, a gown and gloves. And although it is droplet, because it's a new disease and we're still learning about it, they do recommend the use of an N95 as opposed to just a surgical mask. So similar to your COVID PUIs in patients, you want to use the same kind of protection. In terms of cleaning and disinfecting, this is an enveloped virus and they tend to be very susceptible to your standard disinfectants. You would want to pick an EPA registered disinfectant that does claim to have efficacy against emerging pathogens. And so here's a link to the list. You can look at that yourself. But the typical disinfectants that are going to be used in a healthcare or hospital setting are going to meet this requirement. Laundry is a little tricky because, as I noted, you can spread this by fomites, and there's sort of two mechanisms. One, the person could be carrying the laundry and expose their skin surfaces. But the other is if you're like me and you have dogs, I shake out my sheets before I throw them in the wash so I don't clog up my washing machine and my dryer. And that's the kind of thing you wouldn't want to do because you would then aerosolize potentially infectious material. So you do want to make sure you take appropriate precautions in your laundry process. So what do you do if you have healthcare workers who might have been exposed? The monitoring is for 21 days, and that's because, as I described early on, that the incubation period can be as long as 21 days, and this would be after the last day of exposures. You do not need to exclude exposed healthcare providers from work, and you want to actively surveil them, and the recommendation would be to take their temperature twice daily, and then just to do a symptom check by authorized personnel. Obviously, look for a rash as well. Under other circumstances, particularly if it's a large number of people or if the exposures are minimal, rather than active surveillance, you can just suggest to them that they monitor themselves check their temperature a couple times a day, monitor for symptoms, and of course notify you immediately if they were to develop fever and or a rash. I do have the link to the CDC recommendations about monitoring healthcare workers here so that you can look at it in a bit more detail. I mean, the bottom line here is this disease is not nearly as contagious as diseases that we've been dealing with lately. Doesn't mean we shouldn't take appropriate precautions. But again, as I noted, we don't have any reports of healthcare transmission that's taken place across the United States with following these recommended protocols. So what would you do if somebody had an exposure that was concerning? If they had a really concerning exposure, so they had unprotected contact, so they're not wearing their PPE and had direct contact with infected material, or they were in the room during an AGP and were not wearing an N95 or eye protection, that's considered a high-risk contact, and that person, you would probably want to give them post-exposure prophylaxis. The thing about post-exposure prophylaxis is timing is super important. If you remember, the way that we eradicated smallpox was as the last cases were occurring, we did ring vaccination. So what we did was when there were those last cases, we as quickly as possible vaccinated everybody around that case. So like all of their household contacts or other close contacts, and then vaccinated those people's contacts as well. So that's why it's called ring, because it was a ring of protection, around that vaccinated person. However, what the data have shown from that smallpox eradication using these older vaccines like Dryvax is that if you could get them vaccinated within 4 days of the initial exposure, you had a really good chance of preventing them from developing signs of infection, probably about 85%. After 4 days, that really drops off and you have much less likelihood of preventing infection. You may make the infection less severe, and that may be true all the way out to 14 days. So you can actually give post-exposure prophylaxis as up to 14 days out, but ideally you want to get it within 4 days. And because of that data we have in the smallpox elimination campaign, that's where the recommendations come from for monkeypox. And although this would be typical of ACAM, which, as I said, is a live vaccinia virus, we're using the same recommendations for Jynneos, which is a replication incompetent virus. So ideally, you want to do it within 4 days, but you can do it up to 14. So moving on to an intermediate risk contact. So this would be somebody who's within 6 foot of an unmasked patient for more than 3 hours. So that gets back to what I was saying before, that although it could be transmitted by droplet, that is not an efficient mechanism of transmission for this virus. And if the healthcare worker was not wearing at least a mask, and then if you had contact with the patient's skin without a gown, but you were wearing all the other stuff you're supposed to, so a mask and eye protection and gloves, that would be somebody you would consider possibly giving post-exposure prophylaxis to. Basically, it'd be what they would call clinical decision-making, where the person exposed and the healthcare provider would have a discussion of the risks and benefits. I will tell you the risks of vaccination, since we're using Jynneos, are pretty close to zero. I mean, obviously you can be allergic to anything, so that would be the main consideration. Other than that, because it's not a live vaccine and all the complications associated with giving it are the typical ones you see with most vaccines, like a sore arm and that kind of thing. So really, it's a very low risk and lots of potential benefit, but again, it would be shared decision making. And then somebody who really doesn't have what we would consider exposure, if they happen to enter a room but didn't wear eye protection, or if they were within 6 foot of a patient who was unmasked but less than 3 hours, or those that are unexposed, we would not recommend that they get post-exposure prophylaxis. Finally, I will note that this is with the use of the Jynneos. ACAM 2000 could also be used for this, although because of the risks of a live vaccine, there's a lot less enthusiasm about that. But if this becomes more widespread, that discussion may change. But the other thing that's being discussed is whether or not TPOXX or tecovirimat could be used for prophylaxis in somebody who's high risk. So in other words, rather than waiting for them to actually develop disease, could you give it to them similarly to what we do with Tamiflu and our high risk patients who are exposed to flu? So it's not been approved for that yet, but it is being discussed. And I think in a limited circumstance, this could be considered. At this point in time, if you had such a patient you wanted to consider, we'd probably have to contact CDC to get their permission because it's off-label use of this. So what do we want to do with regard to working these cases up? If you have a suspect case and you want to collect specimens, and we'll talk about the details of them in just a second, we do ask that you contact the Imperial County Public Health Department. Keep in mind that we are not taking specimens. The specimens are going to go to commercial labs, and we'll talk about that more in a second, as I noted. However, we still need to be notified because we are going to initiate contact tracing and investigation as quickly as possible. Here are the numbers that you could call. During the day, you can call the disease reporting line, which I have listed here. After hours, you call this other number, which would get you to our duty officer, who then could get you to the right person if the person who answers the phone is not them. As I was noting, CDC is no longer the only lab that is doing these tests. They have made their test available to many commercial labs. And so the typical large scale labs like Quest, LabCorp, ARUP, and many others are now offering this test. It's important to understand that, for example, I believe Quest had actually developed their own lab test. Many of the others are actually using the CDC assay. But their CLIA certification varies by what they did to get certified. And why that's important is because that means that the type of swab that you use to collect the specimen and or the number of swabs and or the transport media that you need to use could vary by the test. Each of these labs has details about what you can use for their particular test. So what you need to do is find out which test your particular site is using, and then follow the instructions for that test. And they do have them online. I have looked at most of them myself. So it varies by the lab, and you would need to look it up. So if you're using LabCorp or Quest, you can go onto their website, you can look up monkeypox test, and it will have the details of what kinds of swabs you can use, how many swabs to collect, and what type of transport media. We're not using the public health lab system now, except in very limited circumstances. So you want to access whoever your private lab is to get these things done. They will also give you instructions with regard to the shipping. These are biohazards, but the good news, they are considered to be the lower level or level B, which makes the shipping a lot easier. So I did put some links to various references and resources. I would really like to call out the CDC COCA calls and also the call that IDSA has done that really has given a lot of useful information, lots of pictures, descriptions of cases. They've talked about the experience in New York and all the patients that they've been treating with tecovirimat. So I would absolutely recommend these to you guys. And of course, the CDC and the CDPH websites have lots of useful information. So let me stop for a minute and let me take a quick peek at the chat, see if there's any questions in there. So it looks like Dr. Stats asked the question, if someone gets a live virus, are they dangerously immune compromised they're in close contact with? Does isolation need to occur following live vaccination? So looking at that in both directions. So somebody who is immunocompromised, they would not be receiving the live vaccine. I think what Dr. Stats is asking me is, what about their household contacts? And that's one of the problems with ACAM 2000 and the DryVax before it, is you cannot give it to people who have people that are at high risk of complications in their household. So that would be a pregnant person, an infant less than 1, somebody that's got skin disorders like eczema, because they're at increased risk, or if they're immunocompromised. So to Dr. Stat's point, if you are a household member with any of these things to a healthcare worker or other who would normally be recommended to get vaccinated, you would not be able to use the ACAM 2000. Okay, so let's see, got another one in the chat. Should a person who has received smallpox be vaccinated again? Really good question. Thank you for asking, because I meant to say that and was going to save it for the end. So if you look at the recommendations that came out from ACIP, and if you're like me and you're a geek and you like this stuff, I did actually go back and look at the archived ACIP meetings for orthopox vaccine recommendations. The recommendations for revaccination are for people that work with orthopox viruses who have been vaccinated. For the most part, that would be somebody who either received ACAM 2000, which is the only one I think since 2007, if I remember correctly, or somebody like myself who's old enough that they would have received the older Dryvax vaccine. If you're working with sort of less concerning or less virulent viruses like Vaccinia or cowpox, they recommend that you be revaccinated every 10 years. And that would be either with ACAM 2000 or with Jynneos, depending on which one's available and whether or not you have contraindications. For people that would be exposed to and or working with the more virulent ones, so that would be anybody working with smallpox, that would of course be a very small number of people, perhaps at CDC or in Russia, or who are working with monkeypox, they recommend that you be revaccinated within 3 years. And so I did actually ask this exact question on our call last night with the state health officer, because we want some clear messaging and guidance to come out so that we're all following this the same way. Because as of yet, in the populations that we are vaccinating, the vast majority of these people would not have received a smallpox vaccine in the last 3 years, so it's probably irrelevant. But particularly as we're looking at laboratorians and other research scientists who are working with these things, we do have to follow the recommendations for them. So I think the bottom line is it would be 10 years for things like Vaccinia, but since we're dealing with monkeypox, then revaccination, if this outbreak continues, based on current data, are every 3 years. Interestingly, they're doing a study in the DRC, Democratic Republic of Congo, which was part of the way that the Jynneos got approved. And they vaccinated 1,600 healthcare workers, 2 different cohorts, but a total of 1,600. And what was very interesting, in the first 1,000, they followed them for 2 years. And there was a very high incidence of monkeypox in healthcare workers in that area who were taking care of the patients. Obviously, they follow different practices than we do here. They had a rate almost 4 times what was seen in the general population. And what they found was there was not a single case of monkeypox in that entire 1,000 people that were followed for 2 years. There was one case that occurred 3 or 4 months after the 2-year follow-up. But interestingly, they did a lot of detailed analysis of that case and found that that person probably didn't respond and probably has some other issues and maybe immunocompromised. And so they were a special case. In addition, there's another 600. They received a slightly different formulation of the Jynneos, and they haven't followed them quite for 2 years yet, so they don't have long-term data. But at least as of when they did the presentation at the ACIP meeting, no cases had occurred in that cohort either. The other thing that I would say, because this question often comes up with regard to 1 dose versus 2 dose, the company that actually developed this vaccine, it's a European company. That's where the BV comes from. It's their name. The data they presented when they looked at responses to vaccination were quite interesting. They actually followed 2 cohorts, one that got a single dose of ACAM 2000, and another cohort that got 2 doses of the Jynneos. And they looked at their serologic response. What they found is that 2 weeks after the first vaccination of the Jynneos and the single vaccination of the ACAM 2000, that their antibody levels were actually the same, almost identical. And the reason that's important is because we have traditionally considered that there's some protection from Dryvax or ACAM 2000 after 2 weeks because the take responses occurred by then. So my point is that there's some evidence that a single dose does give some protection as early as 2 weeks after receiving it. However, in the ACAM 2000 group, their levels of antibodies continued to increase and reach their maximum at 4 weeks. And that's why the recommendation is that somebody's considered to be fully protected with ACAM 2000 after 4 weeks. Keep in mind that they had viral replication that continued on until their body cleared it. So they had continuous stimulation. So that's why it makes sense that their antibody levels will continue to rise. For those people who received their second Jynneos booster, so 4 weeks after the initial dose, they then had increasing antibody levels. And by 6 weeks after the first dose or 2 weeks after the second dose, their antibody levels were again comparable. In fact, they were slightly higher than those of the ACAM 2000 cohort. So the point of this is, based on antibody levels, you definitely have evidence of some protection within a few weeks after the first dose, and that based on antibody levels, you have a similar protection 2 weeks after the second dose as compared to one dose of ACAM 2000. They did actually, interestingly, the CDC did some experience in the lab in which they took smallpox smallpox virus, and they looked for neutralizing antibodies and compared the two of them. The ACAM 2000 levels were slightly higher, but they were not statistically significant. So I think that's the reason that Jynneos actually does have an indication and approval for both smallpox and for monkeypox, because it actually does have data for both of those viruses. ACAM 2000 is an emergency use authorization for monkeypox because there really are limited data with regard to its use specifically for that virus. All right, I don't see, let me see if there's any more in the chat while I was talking. I don't see any so far. Okay, I don't see any other questions, so let me stop, and I am more than happy to take oral questions if anybody has any. And Jeanette, I don't know, how does somebody unmute? Do they just click unmute on their computer or their phone or whatever?
Yes, they just click on mute, and just a quick comment, the slides will be made available to you. So we'll be sending those probably to Mr. Tom Henderson, and if I do have your email address, I can send it directly to you.
And we're gonna see some cases, guys. So it's good to be ready for this. While I'm waiting to see if there's any other questions, I'll just make a few comments on the availability of the vaccine. You may or may not have heard that the county actually received 40 doses of Jynneos. Obviously, it's a very small supply, but we were happy to get some. And so what we did was we reached out to our partners in the community, and really, because it's such a small number of doses, we wanted to target the highest risk population. So we went and made it available to our HIV clinics. And so that initial 40 doses, we held a few of them, so we have them at the health department just in case somebody gets exposed and we needed them urgently for post-exposure prophylaxis. But we sent the rest of them to Intercare so that they could administer them in those clinics and get the high risk people vaccinated as quickly as possible. We totally understand that that's a very limited number of doses. And when the second allocation was due to come out, Imperial County was not slated to get any doses because we have not had any cases. And literally, our first case came right as that other allocation had been determined, and they were getting ready to send it out. And the good news is that I was able to reach out to the state and say, hey, we have a case now, we need some. And we have requested another 100 doses, and that has been approved. And we will be receiving those, and we're going to again send those out, and we're reaching out to additional partners to get this geographically around the county, and again getting it to this highest risk populations. And we will continue to do this and continue to ask for more and more doses. And as the amount of vaccine hopefully becomes more readily available, then we'll expand the populations that we make this available to. So again, let me stop talking, and happy to take questions.
Dr. Sampath here, a quick question. Thank you for answering the previous question. Do you know the turnaround time for the lab test to come in if I were to send a sample today?
Yeah, so of course it depends on the tricky part we have in Imperial County is it's always the transport, trying to get it where it's got to go. We have that same problem at the health department as well. And so it really just depends on what kind of courier system you have, whatever your lab is that you're using. I can tell you, for example, so we don't do the testing ourselves in our health department because our lab is too small and doesn't have the right equipment. So we actually are sending ours to the state public health lab, and it will take at least 2 and realistically probably 3 or 4 days before we're going to get the results back. But I do know that the large corporate labs have said that assuming that transportation is not an issue, that you could expect to get results within 2 to 3 days. So they're really trying hard to have pretty rapid turnaround. And I would note to you that if you have a highly suspicious case And when I say suspicious, clinically fits the picture, and the epidemiology is such as well. It's really important. Everybody that has a rash doesn't have monkeypox. And so you got to do more than just look at the rash. You need to look at the risk factors. Is this an MSM? Have they had contacts in places that would potentially put them at increased risk, et cetera, et cetera? It's really important that you ask those questions, because that's going to be important in the decision making. And so if you do get, an exposure, and you have somebody who has complications that might suggest tecovirimat would be appropriate, then you do not have to wait for lab confirmation. Obviously, you're going to be notifying us anyway, and we'll work with you. But if it's clinically suspicious and the epi fits, we're not going to wait for lab confirmation to treat that person as well. And the same thing, while we're waiting for lab confirmation, that's why we want you to contact us right away. We will start working on the contact tracing to make a determination about whether or not that we potentially need to get post-exposure prophylaxis going as quickly as possible. And depending on the circumstances, again, we may not necessarily wait for the lab confirmation to come back. If we're right on the edge of that 4 days, it's a highly suspicious rash, the epi makes a lot of sense, we're probably going to go ahead and say, yeah, we need to take care of the contacts, because we really want to limit the spread of this.
Thank you.
Other questions? Let me make sure I didn't miss anything in the chat. I don't think so. You guys are a quiet group. Either I did a good job or I was terrible.
It was a fantastic presentation. Thank you for doing that.
Thank you. I appreciate that. I have to say that it's much more comfortable to talk about this now that I've seen an actual patient. It really, really brought to home all the things, of course, that you read and you see and the pictures. And so when you see some of these cases, it's really going to make all this just come into your clear vision, I think.
I have a quick question for the group. We, through epidemiology, send advisories, just different kind of information. But is there something else that you would like to see from us, from Dr. Monday, from me, maybe sent on a more regular basis, a general update? And I'll just share what I do with city managers, city mayors, the schools, is once a month, I send an update, just general update, non-clinical, so that they have the information for situational awareness. For this group, for the medical community, it would be slightly different. Yes, current status, but maybe more of the clinical guidance, the links to that, etc. So are the advisories, the KHAN notices, is that enough, or is there something else that you would like to see?
One comment I'll make to Jeanette before you guys respond in that regard is we are discussing at the state and local levels about whether or not we would be developing a dashboard similar to what we did with COVID, where we would potentially be putting cases on the website and all of that kind of stuff. So we're certainly not there yet, but if this outbreak continues, that preliminary work and discussion is already taking place. So just want everybody to be aware of that as well.
So Ms. Angulo, Dr. Sampat here. So, if you could just notify us if, if our cases go up, because, then we can be a little bit more vigilant, since right now our Imperial County barely has any case. So if that changes, it would be nice for us to be aware. So we are constantly monitoring that. Of course, the guideline, if there's any changes in that, we would appreciate, because we are not constantly looking at guidelines. Only when we hear something in the news, we'll go up and look at the guidelines. Or let's say if there's an availability that opens up, the vaccines, you received them and now you have them. So let's say I see a case today, but my information is from a month before, I'd be more open to discuss treatment options and more vaccine. Of course, we'll notify you, but we are kind of more, happy to have that conversation rather than to defer them to some other place.
Absolutely. So I took a note of that, Dr. Sampat. and maybe going through Mr. Tom Henderson for now. I know there's a transition happening. We'll definitely also get the information out through our epidemiology section, since they have a distribution list already.
Yeah,
And as always, if there's a specific question, or, feel free to reach out directly
Sure.
to me.
Yeah,
Sure,
one
you're always available. Thank you.
Yeah, and one additional comment that I'll make to keep in mind I kind of described when I was talking about the cases is, the population at risk that we have here in our county is very mobile. They're a population that are going to obviously go to Mexicali, they're going to go to San Diego, they're going to go to Riverside, et cetera, et cetera. So, and I know everybody in Imperial County understands this. It's not about always what we're doing within the county. It's, what the counties and states and the country next to us are doing as well, because those things have large effects on us. We have large increases in our day population of people coming across the border, coming across the state line, or whatever, coming and going. And so that's why we just really have to be vigilant here, because even though as a raw number, probably the actual number of people that I would consider to be sort of in the highest risk group is not going to be large, especially considering how many would be, say, in San Diego or LA. They definitely are going to be able to intermingle with populations that are going to potentially have exposures to monkeypox. And so those exposures are going to affect what happened in our county. So if you recall, and I think everybody does, but remember that we sort of had a delayed onset of COVID in our county, because we do have a little bit of isolation, but then all the mingling and stuff occurs, and what happens in the other jurisdictions tends to come into our jurisdiction just with a little bit of delay. And so my concern is that that's kind of what we might see here as well. So just want everybody to be vigilant and just think about it. And obviously, we gave you the numbers. You can reach us 24 hours a day if you need help. That's what the duty officer line is for. The staff know how to reach me. And so if something comes up and you need help, then please reach out, because we want to help you.
Yes, and we're right at time. And Dr. Stats, sorry about that. Dr. Stats, I made a note of your comments as well, so we'll keep that in mind. Well, thank you, everyone. We want to be respectful of your time. We hope you have a great evening, and thank you so much, Dr. Monday, for taking the time to meet with the group.
Yeah, thanks, everyone. Really nice to be on with you, and look forward to the day when we can do this in person again. So good night, everyone, and thank you.
Good night. Bye-bye.